Good morning. Good morning, everyone. Welcome to the symposium being conducted by the Asia Pacific Glaucoma Society. So, I would just like to introduce the chairs and the speakers. So, I am Dr. Tanuj Dada from RP Center, AIMS, New Delhi. Our chairperson is Professor Paul Healy from Australia. He is the president elect of the Asia Pacific Glaucoma Society. We have with us on the chair Dr. Kazuhiko Mori from Japan. He is a board member of the Asia Pacific Glaucoma Society. This session is going to be moderated by Dr. Amit Porwal, who is on the scientific committee of the All India Ophthalmic Society, and we also have Brigadier S.K. Mishra, who will be joining us as a co-convener. So, without any delay, I would now like to invite Dr. Paul Healy, who will be giving the first talk, Genetic Risk Scoring for Glaucoma. Welcome, Paul.
Thank you very much, Tanuj. So I've been asked to speak this morning about genetic risk scoring for glaucoma, which I think is going to completely change the way we evaluate and manage this disease. I know that's a big claim, and I have an interest in it as one of the investigators of the project which has been going perhaps the last 15 years in Australia. We're funded by Australian government trials. That's the only financial disclosure. I have no commercial interest in the startup that provides these genetic services. And also, I think the most important disclosure is this is a huge project, as any genetic project is, involving hundreds of scientists and clinicians from around the world. The lead investigator and the driving force behind it is Professor Jamie Craig from Flinders University in Adelaide in South Australia. So, before we talk about polygenic risk factors, let's ask ourselves why risk factors are important in glaucoma. And the best way to describe this is something I call the state, rate and risk factor concept of glaucoma. And it's something I teach all my students in their very first introduction to glaucoma. If we take a graph with two measures, time on the x-axis and on the y-axis some measure of glaucoma disability, of dysfunction, or in this case, which we can do with OCT, a measure of the percent of the ganglion cell layer remaining. There's a number of possible trajectories in someone's life. In green, we have a normal person who doesn't have glaucoma, and it may be surprising, but that loss of about 25% of your ganglion cells is probably about right over your entire life. At 25% loss, we have the threshold for which someone may present symptomatically with the disease. And then, of course, only a little below that, we have functional and legal blindness. And this, as you all know, is the great dilemma of glaucoma. Subjective presentation occurs very late in the disease, and it's the greatest of all risk factors for blindness. So let's imagine a couple of possible glaucoma scenarios there. And let's imagine you examine this patient age 40 years old. What you measure is the state, and the state you find is not very bad. Perhaps the neural rim is a little narrowed in one sector. Perhaps you'd make a diagnosis of early glaucoma. But that diagnosis of state and the fact that this person is totally asymptomatic tells you nothing about what the future holds. Their path may be in the green, in the orange, or in the red. And what determines that, of course, is the rate. Now, the difference in rates makes a very big difference to that patient. If they progress at normal aging, they will die of old age with no perceptual functional loss. If they follow the orange pathway, they will start to notice visual symptoms in their 80s, but still be functional by the time they die. If they follow the red path, they will be functionally blind from age 60. So, the obvious question is, what determines that rate? And of course, it's risk factors. So this is why the risk factors are, in fact, I think, the most important concept of the three, because we can't do anything about the state. We can do things about rate by lowering intraocular pressure, but we've got to make the right decision. You know, we can overtreat people and blind them, or we can undertreat them and let them go blind. And the velocity progression is enormously variable in glaucoma. So better establishing those risk factors is what tells us who to treat and who we don't need to be so aggressive for. So it's extremely important. And, with 10 or 15 years of risk factor research on my part, prior to genetics, we couldn't create a risk factor model that sufficiently accounted for that variation in velocity. So what's genetic risk scoring? Well, it's simply using genetic markers as part of that risk modelling for incident glaucoma. And here's a paper from about 10 years ago when we started looking at these risk alleles, which are these things on the table that say RS, and they're best thought of as particular genetic variant, single nucleotide polymorphisms, which seem to convey an either increased or decreased risk compared to the wild type or the normal polymorphism for disease. And when we look at those risk alleles and we compare them to other clinical risk factors such as systolic blood pressure, mean intraocular pressure, or age, or sex, we see that their effect is rather modest. So if you look at RS465, you'll see that the increase in risk by having that allele is about 84%, which is important, but it's not very strong. It's not a 10 times risk. So while genetics looks useful, none of these individual genetic risk factors seem to be strong. But if we model how important they are, and this is from the same paper looking at neural network modelling of the contribution to risk, what we see, which is very pleasing, is that while those clinical risk factors such as the mean cup disc ratio and mean intraocular pressure stand out, so do these risk alleles. And in fact, they are stronger than other measures. So they look very promising. The question is, how many risk alleles do you need to meaningfully be able to predict disease? And the answer is you need a lot. And this was the landmark paper from 2020, which allowed us to develop this polygenic risk score. So it was designed to identify prevalent glaucoma, open-angle glaucoma, unrelated to intraocular pressure. But when you do that, you're going to pick up genes that are involved in high pressure because of the relationship between high pressure and glaucoma. 330,000 European genomes were used, and that was simply because they were available. 45,000 Asian genomes, 6,000 Africans, from 21 independent studies, and that gave us about 34,000 glaucoma cases, of which 20% were self-reported. And this was replicated in a commercial database from a company called 23andMe, which you may have heard of, which is a direct-to-consumer genetic analysis company, for which we added 1.5 million genomes, of which there were 43,000 self-reported glaucoma, about 2,700 single nucleotide polymorphisms. And then that model was tested on an independent clinically validated dataset such as the Australian New Zealand Registry of Advanced Glaucoma, the Progressor, which is a cohort study of early glaucoma, various population-based regional cohorts such as the Liverpool cohort, and population-based studies such as the Blue Mountains Eye Study. What we found is that those loci were actually similar across different ancestry. So Africans, Asians, Europeans didn't vary greatly in the kind of genes that contributed to glaucoma. The loci were similar in both high and normal tension glaucoma. There was a strong association between the PRS and glaucoma, and there was a similar performance in clinically identified and self-reported cases. So there wasn't a major self-reporting bias in glaucoma. They really were glaucoma, they weren't just ocular hypertension. How strongly does it predict glaucoma severity? Well, if you look at the figure on the left, there's about a 15-fold difference between the bottom decile of risk, so the lowest PRS risk group, and the top. And if you look at the two different studies, the Southampton on the left, the Australian on the right, you see that increase is similar, although to a slightly different level. It's more like 10 or 12 times in the UK, 15 times in Australia. But that was found consistently throughout all the clinical replicas. And similarly, it was strong in both high tension and normal tension glaucoma. Again, you see it's stronger at the higher risk levels with high tension glaucoma, as I said, because when you do a glaucoma PRS, you're going to pick up genes for intraocular pressure, and that's the reason that those two differ in terms of the size. Interestingly, it predicts clinician behaviour and disease state despite clinician behaviour. So this was in the ANZRAG data study, people with advanced glaucoma in Australia on the left there with severe glaucoma. And if you look at the probability of having a trabeculectomy, as you would hope, it goes up the higher the risk factor. So we can look back and go, well, all those people up at that 90th decile, they all end up needing surgery. And that's very useful information to know when you're first seeing that patient. If we look at the other graph, you can see that as the risk decile increased, the surviving ganglion cell layer, in other words, the nerve fibre layer left, gets worse. So despite everything we do, people at the high risk gets worse faster, but also people at the low risk don't get worse. So these may include patients we're just observing. So actually that is quite good. It tells us that as clinicians we're doing the right thing, but it gives us the opportunity to identify those patients not because of their progression or lack of it, but at the very start. It also strongly modifies the association between age and intraocular pressure. So it was a Blue Mountains eye study that first identified the exponential relationship between open-angle glaucoma prevalence and age, and coincidentally that was my first glaucoma paper, and that was 30 years ago this year. So we know very well what we should expect glaucoma rates to be at different ages, and at age 70, we should have a rate of about 1.5%. And if you look at the bottom decile at age 70 in that figure on the left, you'll see that it's somewhat below that. But if you look at that top decile, it's up above 15%. So the PRS decile alone, there's a 6-fold difference in risk at age 70 between being in the top and bottom decile of having glaucoma. It predicts earlier age of onset, increasing proportions of the disease at older age, and as I said, that at age 70, if you're in that top decile, 1 in 6 will have the disease. And this is in the UK Biobank, so again, another cohort that's been well genetically defined. It predicts earlier onset of disease. The PRS alone identifies 30% of self-reported earlier onset of glaucoma, in other words, under 60 years in the UK Biobank. And in the Blue Mountain study, predicted 40% of earlier onset glaucoma. However, if you make the data set bigger, all those numbers get bigger. And in 2025, our data set now has over 6 million genomes, over 1,100 loci, over 7 million single nucleotide polymorphisms. And that top decile, 10 times risk, is not between the top and bottom decile now, it's between the top decile and all the other deciles. And the top to bottom decile in ANZRAG is now almost 100 times. So as more patients get the test done, as we expand, the power of this polygenic risk scoring will get even stronger. So if we look at the incidence of glaucoma in the 15-year follow-up to the Blue Mountains eye study, the top PRS decile developed glaucoma on average more than 25 years before the lower decile. It predicted the absolute risk by PRS decile. If you're in the lowest 5th decile, the prevalence of glaucoma was 0. If you were in the 90th, it was 20%. And if you were up in the 99th, your chance of having glaucoma was 50%, the highest risk factor for glaucoma. So what does the test look like? It's a small box with a swab inside. It's a buccal cheek swab. It's cheap, it's easy, and it's not painful for the patient. When we started, it was about 210,000 rupee to do a genomic analysis. It's now 21,000. In a few years, it'll be 2,500, which will be cheaper than seeing a doctor. And when it costs 250 rupees, I think everyone in India can afford to do this test. And it's accessible. You don't need a doctor. You don't even need examination. All you need is some sort of postal service to get your sample off to the lab. So, in summary, how can we use this genetic risk profiling to change our management of glaucoma? Because a high PRS for prevalent glaucoma identifies earlier onset, more rapid progression, more advanced disease in the future, and the majority of cases in older populations. A high PRS for prevalent glaucoma predicts clinician behaviour in advanced disease, progression despite treatment, and risk of incident glaucoma in a normal eye. But conversely, and very importantly from a public health point of view, a low PRS for glaucoma identifies high survival of nerve fibre layer in early glaucoma no matter what you do, more benign disease with less progression, and a low PRS for prevalent glaucoma importantly identifies patients who are less likely to have a change of management, who are a population who probably don't need to be monitored by doctors, and in fact for some patients don't need to be monitored at all in their life for this disease. We're not there yet. There are some important future developments to come, larger data sets with more diverse ancestries, particularly in Asia, integration with clinical science, such as using machine learning, specific PRSs tuned to progression risk and diagnosed patients, glaucoma subtypes, non-glaucoma population, visual disability, and of course treatment response, and lastly a PRS for angle closure disease. Thank you very much.
Thank you, Paul, for your excellent lecture highlighting a very new important risk factor. Our next topic going to be given by Dr. Benjamin Zhu from the United States of America, and that will be covering artificial intelligence in glaucoma from hype to reality. Welcome, Ben.
Okay. Good morning, everyone. It's a pleasure to be here with all of you today. I'd like to thank the conference organizers for inviting me to speak. I'd like to acknowledge my funding sources before I begin, including the National Eye Institute and various foundations. I don't have any other relevant financial disclosures. Artificial intelligence, or AI, is a transformative technology that in a very short period of time has become an essential part of the way that we live, both at work and also when we're at home. This has entered our collective consciousness through very useful tools such as large language models, ChatGPT and Gemini. And at the same time, this technology can also be very disruptive to the world's economy when new technologies are introduced or when there is insufficient resources to power this technology. At this current time, we don't yet know what our relationship with AI will be like in the future. There is a lot of apprehension about this technology, and I think it still is yet to be told whether the technology will be more friend or foe. In regards to the role of AI in healthcare, there's tremendous potential for AI to improve access to care, especially for patients in underserved areas. It can also improve the quality and standardize the reproducibility of eye care, and perhaps it could also help us reduce the cost of care as well. We've known for a while that AI can be used to detect patients who are either at risk for glaucoma or who have glaucoma. This was a landmark study published by Daniel Ting and colleagues in JAMA in 2017, where they developed a model for detecting a wide range of eye diseases, including referable glaucoma. And the model performed very well because the authors used a very large data set. And so there's been an explosion of AI research in the field of glaucoma over the last 10 years or so. Just last year, there were nearly 300 publications on these two topics. And the research, on the research side, there's been a rapid development of different models. These describe models for detecting glaucoma in fundus photographs. These describe detecting glaucoma in OCT images. And my own lab has published papers detecting glaucoma risk factors such as angle closure using either goniophotographs or anterior segment OCT images. But the question here is that right now this seems more like scientific hype. When is it actually going to become a clinical reality where we are using this technology for the care of our patients? And how do we bridge this gap? So I would say that bridging the gap between hype and reality requires a compelling clinical need for this technology. And I'd like to talk a bit about the emerging glaucoma care crisis, not just in the United States, but across the world. We know that the burden of glaucoma is rising worldwide. There are more and more people with glaucoma due to aging of the world's population. And at the same time, in many countries, including in the United States, the size of the ophthalmology workforce is declining due to physician burnout and earlier retirement. And we know that when patients have difficulty accessing eye care, that they tend to be at higher risk for vision loss. And so this highlights the importance of access to care, especially in underserved populations. This was a study that we conducted with Kaiser Permanente. This is a very large managed care health system in the Western United States that serves over 14 million people. And we collaborated with Kaiser Permanente to look at the effectiveness of their glaucoma referrals. So these are patients who are between the ages of 18 to 40 who are being referred for glaucoma evaluations. And we looked at a cohort of nearly 300,000 patients. And we found that among those who were referred for glaucoma evaluation, only 8% of them were diagnosed with glaucoma, which suggests that we aren't really utilizing the resources that we have very effectively. We developed a very simple risk stratification model, and we identified that more than half of these patients had a predicted risk of less than 5%, and yet they were still referred for glaucoma evaluation. And so this shows we need better tools at the point of care to risk stratify our patients and identify the high-risk patients who need care. And so the clinical need here is really a novel strategy to address the rising demand for resource-efficient glaucoma care. Telemedicine is not new. Telemedicine has been around for several decades and is an alternative means of delivering care using technologies that are now widely available, such as teleconferencing software. And in Los Angeles, we use telemedicine and specifically teleophthalmology in order to detect patients who are at high risk for eye disease, such as diabetic retinopathy and glaucoma. We have a program that is spread across 17 sites in Los Angeles, and patients go to have fundus photographs taken, and these fundus photographs are interpreted by optometrists to detect eye disease, and more than 2,000 patients per month benefit from this form of eye care. Despite the wide usage of this technology and this care pathway, there are limitations in how glaucoma patients are detected. So right now, glaucoma patients, or rather patients are evaluated for enlarged cup-to-disc ratio of 0.6 or greater. And when they exceed this cutoff, they are referred for in-office evaluation. But we identified some limitations in this workflow. There are delays for when these images are reviewed by optometrists. There's high variability among optometrists and human graders in general for detecting referable glaucoma. And there's also static referral, which means that everybody who is detected as referable goes to see the doctor and waits in the same line. There is no prioritization of the visits. So we thought that we could use artificial intelligence here to enhance this workflow to deliver care in a more efficient fashion. So a few years ago, we established the ATLAS initiative. ATLAS stands for AI and Teleophthalmology in Los Angeles. And this is a multidisciplinary collaboration between clinician scientists, clinicians, computer scientists, data scientists, and healthcare administrators. And our goals are to deliver eye care to underserved communities, improve the quality and equity of care, and to enhance the efficiency and cost effectiveness of care. So what have we learned about AI use in a real-world clinical setting through the ATLAS initiative? First, we find that AI provides reproducible expert-level performance. This is a paper that we published last year in which we used just over 13,000 images to train a convolutional neural network, which is a type of AI model, to detect patients with referable glaucoma. As I told you, humans tend to have a fairly high variability when it comes to detecting referable glaucoma. And so you can see the performance of 11 human graders, either ophthalmologists or optometrists, their sensitivity and specificity for detecting referable glaucoma. And what we found is that regardless of the grader's level of expertise, that there is this wide range of sensitivity and specificity, which can be overcome with a AI model. And here you can see the AI model. This is the receiving operating characteristics curve that shows the performance of the model. It performed just as well, if not better, than all of the humans. Another advantage of AI is that it is adaptive and scalable. What this means is that for each given human, we have our own inherent sensitivity and specificity, but if we are to be overly sensitive in referring patients, there is no way for us to scale back the number of referrals to suit the capacity of the healthcare system. The nice thing about an AI algorithm is that if we find we're over-referring patients, we can actually change the operating point for the model so that we refer fewer patients so that the health system is not overwhelmed, and this can be done in a highly reproducible fashion. Finally, AI is highly information efficient, which means that it can derive more predictive information using less data than a human can. More recently, we've been developing more sophisticated models to detect not only referable glaucoma, but manifest glaucoma. That is, patients who are already beginning to lose visual field from their glaucoma. And here we developed a model for detecting manifest glaucoma, so anybody with clear visual field loss or damage to the OCT-RNFL. And what we can see here is that here's the performance of the model. This is based only on fundus photographs. And the area under the curve here is 0.8, which is fairly good performance. When we compare it to the performance of human ophthalmologists using just fundus photographs to detect glaucoma, we can see that the that the model actually outperforms the humans, suggesting that it can pick out details from the images that the human eye is not trained to see. When we compare the performance of the model to humans with a full diagnostic set, including visual fields and OCTs, the model is not as good, but we have to remember here that the model is only using a fundus photograph, which is a much more low-cost form of evaluation. So here I presented some strengths of AI, but then the question is, why is AI still not a reality in glaucoma care? And so there are a number of barriers to adoption that I'll briefly go over. One is that in the field of glaucoma, we lack standardized definitions of disease. In diabetic retinopathy, there's very clear staging of disease, but in glaucoma, we only have this very broad and general definition that makes it difficult for us to train AI algorithms in a reproducible fashion across studies and sites. Another issue is this issue of data interoperability. In glaucoma, we evaluate many different data sources, and there are different devices and software vendors. And so it becomes difficult to bring all of this data together into one place for the algorithms to function. Another issue is patient privacy. When we bring data into these models, oftentimes these models are hosted in the cloud, which exposes them to loss of privacy. And so here's an example in the United States where Kaiser Permanente, with its 12.4 million members, lost privacy, patient privacy, and had to pay $46 million. Device regulations is an issue. In the United States, AI is considered a medical device, and so it's tightly regulated by the FDA. And so without clear disease definitions, it can be very difficult for us to get glaucoma detection algorithms approved. An issue that has been emerging recently is AI apprehension. This is a study we performed last year where we compared the performance of human graders, specifically ophthalmology residents in the United States, to a last generation of large language models. And what we can see here is that the human performance, even compared to the worst large language models, was no better than the AI. And so it leads to this worry that as we develop this technology, we may be replacing ourselves. And this apprehension is only growing as the performance of the AI is improving. So here you can see at the very bottom is the human performance on multiple choice questions. And then all of the large language models in the current generation outperformed the humans. So perhaps in the future, though, these types of technology, such as large language models, could be a useful tool for diagnosing our patients. This is a recent study where we used off-of-the-shelf large language models. And what we did is we took all of the clinical and diagnostic data and fed it into the large language models without any sort of pre-training. And what we did is we looked at the agreement between either a human and a panel of glaucoma experts or the large language model. And what did we find? We found that agreement between humans tended to be fair, anywhere between 80 to 90% or so, but that this agreement was matched by the large language models without any sort of pre-training about what glaucoma is. And so this suggests that in the future we might be able to use these tools to help us with clinical decision support. So no talk about AI would be complete without asking AI what it thinks about itself. And so I did go into ChatGPT and I asked, in the next 10 years, will AI be the mainstream diagnostic test for glaucoma? And it told me it will, because AI can integrate imaging, functional data, and longitudinal trends at a scale and consistency that humans alone cannot, making it the default way glaucoma is diagnosed and monitored. So I'll let you mull over this statement. But in summary, the demand for glaucoma care is rapidly rising worldwide. AI provides a potential solution to meet this rising demand. However, we do need more real-world implementation studies in diverse settings and populations before we can really understand how best to use this technology to care for our patients. I'd like to acknowledge the hard work and contributions of all the members of my lab, and thank you very much for your attention today.
Thank you, Ben. It was a superb talk, well curated. The next speaker is Dr. Kazuhiko Mori. He is going to talk on mixed and primary angle occlusive disease.
Okay, thank you for okay. My name is Kazuhiko Mori from the Kyoto, Japan, and I'd like to talk about mix in primary angle closure diseases. So this is my university hospital in the Kyoto, and then my interest with the disclosures are here, but no financial disclosures related to this presentation. So I'll present one case. The case of 31 years female, and then she requested for the further treatment for the persistent high IOP after the clear lens extraction after for the APAC. So her visual acuity is good on the right eye and the left eye. That was 0.3, and then both eye IOP was 26 and then 25, and then anterior segment. Right eye is not yet cataract was done, but the left eye is already done with the cataract surgery. And then gonios shows that the right eye is a shape of 1, and then both eye and the left eye a little bit shallow. I show the anterior segment image and also the cassia what she did. And then fundus, her fundus photo shows that the CDL is 0.5, and then she has a retinoschisis on the both sides. So that's why her visual acuity is not so good. And the CCD is all normal, and the XL length is 21. It's not so long, short enough. And then she has a family history of the glaucoma with the younger sisters. So this is the anterior segment photos in the right eye and the left eye. So right eye, the cataract the lens is there, but the left eye already IOL. So, but still the peripheral is a little bit shallower. And also the angle says that right eye has a bit indentation gonioscopy still, so a little bit PAS around here and here and here. And then left eye still has a PAS around maybe more than 180 degrees. So it means there's some resistance in the trabecular measure of the left eye. So cassia shows that the right eye, shallow angle, left eye, still some adhesion there, or maybe synechial. And then the main part is here is the IOL is going forward. It's a little bit, the iris and IOL is almost touching. And then also it shows that the cassia 360 degrees. And then there's some PAS still there. So ACD is deep enough, but the IOL has a myopic shift to the anterior portion, and also the peripheral segment is a little bit PAS there. So there are 3 mechanisms of persistent high IOP for these patients. So PAS were there, and also some part is open, but still the IOP is very high. So it means that the TM function is not good enough, or maybe this function there. And also IOL might be a myopic shift, means that AIOC misdirection syndrome was there. So in that case, this is the fundus photo, and then there's no disc damage on these patients. And then she has a retinoschisis already here. So this patient's problem has a persistent IOP rise after the clear lens extraction for the APAC, and then residual PAS after the indentation gonioscopy shows that the PAS index is more than 180 degrees. And then another 180 degrees open, so that means that the TM dysfunction was there. And then also the IOL myopic shift, so mild AIOC misdirection was there. So prevent this one, the treatment strategy is for break up the angle closure mechanism and also the management of the radial glaucoma. So that's why I did for these patients, the diagnosis of PAC plus AMS, AIOC misdirection syndrome. So I plan to do the gonio-synechial lysis, and also together with the mix, I usually do the GAT, hemi-GAT, and also she has a AIOC misdirection, so that's why I chose IZHB, iridosoneural hyaluronic vitrectomy, all together. So this is a video for this patient, and then show you this. Oops. And then this corrects is getting out, so it means that the posterior port is some pushing mechanism there. So that's why this from the anterior segment I did the anterior segment vitrectomy, and then also the HV. And then this is the using monogonio lens. I did gonio-synechial lysis, so for this is 180 degrees. And then after that, I did the GAT with a suture, and then suture put into the ceramic canal, and then 180 degrees, and then cut the suture, and then cut it. So in this case, the IZHV plus GSL plus hemi-GAT was done. So with this test, with this surgery, IUP going down to the 3 meter mercury, and then AC is deep enough, and then also the cashier shows a no residual PAS value. And then also the IOL myopic shift is recovered to the deep enough for the no pushing mechanism from the posterior part. So in this case, I showed that there's some different mechanisms are there in the primary angle closure, and also the PAC spectrum is a little bit confusing, but usually we call it PAC S is an apogee-neutral closure in the more than 2 quadrant without synechial, and then PAC is a primary angle closure is a synechial closure without IOP rise, or a positional closure with the elevated IOP. And then also that the PAC has a no optic nerve damage, and then PAC G has a with the PAC with the optic nerve visual field changes. So this is the definition of the spectrum of the primary closure recently. So what is the mechanism of the IOP increase in SPAC? So there are a little bit appositional closure in endotrabecular contact with a small mechanism are there. It calls that a relatively pupillary block between the iris and anterior posterior chamber. And also there's some mechanism of the plateau iris. And if the lens is enlarged or swelling, then there's a lens factor there. And also I showed you that the malignant ACOS misdirection syndrome and the lateral lenticular factor also may cause the appositional closure, so they don't trabecular contact. So this appositional closure leads to the synechial closure. It's a peripheral anterior synechial. And if the PAS developed, then the IOP going up. And then the IOP developed going up, but not only that, also there is some TM dysfunction. And then this caused the high IOP. So, and then long-term PAS caused the histopathological change with the TM. So that's a mention, and then also the shrimp canal may change that after the primary angle closure glaucoma. And then this was the regular cause of the SPAC, like from the SPAC to the PAC, and then PAC to the PACG. But there's some patients has a directly from the ITC to DM dysfunction. There's no PAS, but the IOP is still high in some patients. So that means that there's direction for the positional closure to the TM dysfunction. So in that case, the surgical procedure for the SPAC, we can think about that. Lens extraction itself is not enough for the IOP reduction for the residual PAS or the TM resistance. And then also there's a problem with the lens extraction for the SPAC has a PAS recurrence may occur because some PAS may be adhesion are there, then it's a pulling mechanism are there, so residual PAS expansion may occur. So in that case, that means the lens extraction is not only good enough for the SPAC or PAC-G surgical procedure. But how about the trabeculectomy? So trabeculectomy is a PAA plus IR, so spherical trabeculectomy. This is a good, I know originally it's a good technique for the SPAC, and especially for the end stage of the primary angular glaucoma. But it is some risk of the shallow anterior chamber and then APGS misdirection, like these patients. And then also some risk factor of the blood-related complications. So recently, we have another option for the surgical procedure for the SPAC. And one is a GSL, and then the other one is a GSL plus gap, or maybe the mix. So, but the GSL with a cataract is directly break up the TM obstruction by synechial closure, but less effective on the high IOP with TM dysfunction. And then there's some patients with, after the GSL, still IOP is still high. It means that the TM is not working well. In that case, we need another surgical procedures. So that's why recently we have a lot of study right now with minimum mix and the PACG. And then this study shows that cataract surgery in combination with a mix, it can be safe and effectively performed in the PACG. And then also another study shows that phacogoniotomy was non-inferior to the phacotrabeculectomy in terms of the IOP reduction for the advanced PACG, and then cataracts. So there's some option for the surgical procedure for the PACG. So this is a third option for the mix with PA plus IOL with a phaco mix. But it's effective on the high IOP with a positional closure. And also, but there's some risk of the iris root damage if the strong synechial is there. And then there's another issue about the glaucoma and then about the mix. And then we have some the Japanese studies show that glaucoma medication and the mix show that after preoperative medication that does not involve the conventional pathway outflow, but detrimental effect on the subsequent Schrems canal surgery outcomes. So it means that the mix is less effective for the patients with a disuse atrophy of the conventional outflow. So it means that the long-standing PAS of the SPAC may have the same effect on the Schrems canal. So GSS mix has a breaks for the PAS and the TM resistance and less effective on the TM disuse atrophy. So in the take-home message, aqueous misdirection is one of the mechanisms of angle closure. Lens extraction is indispensable for the treatment of the SPAC, and then phacotrabeculectomy is also indispensable for the severely damaged PACG. Although, cannot see, cannot read. Okay, although it has lots of adverse effects related to the spread, and then GSL has certain effects, but not enough for the non-functioning trabecular measure due to the long-standing PGS. And then GSL plus mix is another good surgical modality to enhance the outflow facility through trabecular measure in chronic angle closure, but may not enough for the long-standing TM dysfunction. Okay, so I'll tell you that next year in April, we will have the 12th World Glaucoma Congress in Kyoto, so please welcome you, and so thank you very much for your attention.
Thank you so much. Now we have the next speaker, Dr. Nitika Berry. She's going to speak on trabecular bypass insights from aqueous angiography.
Thank you, sir. Can I please have the slides? AV team. Dr. Nitika Berry. Yeah. A very good morning to all of you, respected seniors and dear friends. I would like to thank AIOS organizers for giving me this opportunity to speak on the topic, that is recent advances in glaucoma trabecular bypass, insights from aqueous angiography. Aqueous angiography is a recently introduced imaging technique that allows us for real-time functional assessment of the conventional aqueous outflow pathways. It has shown us a wide variations of aqueous outflow, ranging from circumferential equal outflow to a poor outflow. You can see here the dye is within the anterior chamber here, to a segmental outflow, which is the most common pattern noted. It has helped us to identify a region of high flow, that is a region of increased angiographic signal intensity, and a region of low flow, that is a region of decreased angiographic signal intensity. And this in turn has helped us to plan targeted placements of stents or incisions. Let's quickly look at how this imaging technique is performed. We take fluorescent tracer dyes such as endocyanin green in the concentration of 0.1% or fluorescein dye in the concentration of 0.5% and inject 0.1 ml of this dye intracameral, and as the tracer dyes flows through the aqueous channels, they are imaged using the flex module of the OCT machine in the operating theatre with the patient lying supine during a planned intraocular surgery, such as a cataract surgery. We all know here that trabecular bypass could either be trabecular cutting, MIGS like BANG, or trabecular stenting procedures like iStent inject. For the purpose of this lecture, I shall be talking about insights from aqueous angiography imaging technique for the trabecular stenting procedures. Let's move on to the challenge that most of our MIGs face, that is mild IOP lowering and minimal medication reduction. In a recent report by the American Academy of Ophthalmology, they evaluated 10 level 1 randomized controlled trial in patients of mild to moderate primary open-angle glaucoma patients at 2 years and analyzed the results for MIGS that included iStent inject and hydrous versus with cataract surgery versus cataract surgery alone. And they found that cataract surgery alone led to a 21 to 28% of an IOP reduction, and mixed devices provided an additional 3.8 to 8.9% of IOP reduction over the cataract surgery. The mixed devices, as per the report, gave a medication reduction by 0.4 over 2 years. This report clearly indicates that the impressive IOP lowering that we've been getting is mainly due to the cataract surgeries. So now that we've looked at the challenge, let's analyze together how can we overcome this challenge and improve the efficacy of trabecular stenting procedures. In a previously published literature, the AIOC studies analyzing the iStent inject positioning reported that 72% of the device heads were not positioned within the Schlemm's canal, and the decreased Schlemm's canal dilation was associated with a higher postoperative intraocular pressures. On a follow-up study by the same group, they gave an important conclusion that the surgical outcomes for iStent inject at 12 months was dependent on the initial device implantation. Keeping this extremely important point in mind, we suggest a solution to assess intraoperative functionality of stents during the time of initial device implantation. And for that, we have indirect evidence which is trypan blue stained episcleral venous fluid wave or the blood reflux in anterior chamber. And these can be treated as surrogate markers for checking the functionality of stents. For a confirmatory evidence, however, we would need a tracer-based imaging like aqueous angiography, which would allow us to image these intrascleral aqueous channels like we just saw in the previous slides. So let's together discuss a few cases on functionality of iStents. So moving to case 1. In this case, in figure A, you can see 2 anatomically well-placed iStent injects. And following the insertion of stents, you can see in figure B, we got a good blood reflux in the anterior chamber. And in figure C, on checking with the trypan blue dye, we saw a good episcleral venous fluid wave through one of the stents, indicating it to be functional, whereas there was a lack of trypan blue flow through the other, indicating it to be non-functional. Following this, we performed the confirmatory evidence with aqueous angiography, and you can see here in the image that the arrowhead in the star shows the stents that are inserted within the anterior chamber, and to our surprise, there was a lack of aqueous channels through both the stents, indicating it to be non-functional. So this could be because during stent implantation, there could have been a collateral damage to the adjacent trabecular meshwork, resulting in the blood reflux in the anterior chamber, and there could be injury to the TM leading to microcuts, allowing the trypan blue dye to flow around the circumference of the stent, hence giving a false positive sign of patency. Therefore, a word of caution that these surrogate markers are not dependable to check the functionality of mixed procedures. Moving to case 2. In this case, on your left-hand side, you can see 2 anatomically well-placed iStent injects, and we performed an aqueous angiography after the insertion of these stents, and we found that there were visible collector channels through one of the stents, indicating it to be functional, and absence of collector channels through the other, indicating it to be non-functional. Combining these 2 cases and a few other cases, we did an analysis for the functionality of iStent inject with aqueous angiography. We took 4 cases, that is 8 stents, and found that intraoperatively 75% of the stents were non-functional versus 25% of the stents were functional. This brings us to a new concept. that despite anatomically well-positioned eye stent injects, they may not be functional. And one of the reasons could be due to the variations in the position of the aqueous collector channels, that is the segmental outflow, as has been shown by aqueous angiography. It brings us to a critical question in all of our minds. Where can we target these stents to improve their functionality? So we went back to the literature and found that as per previous literature, the quantitative assessment of functional aqueous humor outflow by aqueous angiography in primary open-angle glaucoma eyes as well as the normal eyes without glaucoma gave us the same result. That is, they found that on quadrant-wise analysis of 90° each, the nasal quadrant had the highest aqueous outflow. And on a further analysis of sector-wise of about 45 degrees each, found that the nasosuperior sector within the nasal quadrant had the highest aqueous outflow. This brings us, keeping this point in mind, it brings us to a hypothesis that we can propose, that is to place the stent in the nasosuperior sector, that is 45 degrees within the nasal quadrant, so that it gives an opportunity for maximum chances of hitting these collector channels. My take-home messages are: 1. Aqueous angiography can help us assess intraoperative functionality or patency of trabecular MIGS and thereby allow us intraoperative adjustment in the same sitting if required. 2. Surrogate markers like trypan blue dye, episcleral fluid wave, and blood reflux in the anterior chamber for checking the functionality of MIGS may not be dependable. And 3, we can plan to place stents in the nasosuperior sectors to improve the chances of hitting the collector channels. I would like to thank Professor Tanuj Dada sir and Professor Sanjay Kumar Mishra sir and the team. Thank you very much for your patient listening.
Thank you, Nikita. So the next speaker is Dr. Shamira, none other than who can talk about the health economics disparities mix in the developing world.
Thank you very much for the kind introduction. These are my financial disclosures. Now, this is an exciting time for us in glaucoma because we have this real paradox where we have all the tools, the diagnostic and the therapeutic, to treat this potentially blinding disease, and yet it still remains the biggest cause of irreversible blindness. We have MIGS coming on the scene right now, which all seems very exciting, but the uptake is very variable depending on the country that you're in, and yet it's also only yielding us modest outcomes. To explain all this, I'm going to go into health economics, and then my next slides are purely going to be on a different subject, not clinical medicine or ophthalmology, but purely on economics. So we know that India is a rapidly developing country, bounding towards its developed status. At present, it has 31% of the population, which represent the middle income group, but it's expected to grow within the next 10 years to 47%. This middle class group is salaried, educated professionals who can comprehend the usefulness of MIGS, but why does it not uptake so well? Interestingly, you can see from the graph at the bottom that the growth in glaucoma surgery devices relatively outperforms the growth in cataract surgery devices. So there is a potential there, even though the pie is not as big. Now, MIGS is a conundrum in India in the present day. There are low rates of insurance. These MIGS devices are universally expensive, and there's a poor access to MIGS, especially in the rural group. Now, the rollout of devices in India has been very, very slow for a number of reasons, and partly because of the lack of government subsidies and the need for out-of-pocket payments. Also, in terms of how these devices are rolled out, the training opportunities are rare. There are several disparities within India, and you can see that there is a gross difference between how these devices are paid for in the public sector by governments and local health authorities. Now, what's changing is this middle class wave. You can see that blue segment from India increasing over the next 25 years. In India, the middle class is defined as households with annual income between 6 lakhs and 18 lakhs. And I heard from good authority that this is about the salary of, let's say, a cook in a restaurant. You can see that area is set to boom. And even in 2035, India's middle class is meant to surpass China's, even though at present the population statistics do look quite different in favor of China compared to India. Now, in India, the middle class is set to grow, and of the next billion entrants into that middle class bracket, 88% will be from Asia, 350 million from China and 380 million from India. And by 2030, 2/3 of the global middle class population could be from Asia. So what do we know about how this affects our glaucoma populations? We know that glaucoma blindness is avoidable, yet it's concentrated in these low to middle income countries because of late diagnosis. In fact, only less than 5% receive this timely intervention because of the late stage of disease presentation. And cost is a primary barrier. So we need these cost-effective analyses to guide what may be sustainable interventions. There are several barriers to MIGS in this population, not constrained to just the cost and availability, but the infrastructure and training, and then even its accessibility over eye drops. Now, we must remember the economics of it all, that you need to look at the out-of-pocket spending in these countries, and this can sometimes bankrupt families. Glaucoma is not just a difficult disease because of the disease burden, but it's also a costly disease. Now, in Western countries, it's taken over by social support and insurance companies, but here it's bound by the families. Now, to look at this, I'm going to introduce a term that you may or may not have come across, which is called the incremental cost utility ratio, the ICUR. And this basically gives you the incremental cost per QALY gained. When it's good, in other words, highly cost effective, this number needs to be far less than the per capita gross domestic product. And when it's very poor, that means it's about 3 times the per capita gross domestic product. Remember, this GDP per capita varies hugely around the world. So you can see what may be cost effective in Singapore may not be cost effective in Bangalore. China is another problem because it has a rural and a urban population, and again, what may be suitable for an urban population may not be suitable for a rural population. Interestingly, you can look at these devices, let's say the ones at 10 years. When you look at TRAB, Ahmed glaucoma valve, ABIC and GAT, despite the differences in the cost of these devices, you can see the cost actually turn out to be quite similar. And this actually comes from something that I heard from Paul. Paul was talking in previous work about how a lot of these costs actually come from the transportation and the hospital visit, let alone the cost of the actual surgery themselves. And actually, when you look at these willingness to pay thresholds, it's actually very difficult to meet these. Simply put, in India, when you have a eye curve for eye stent around about, let's say, 3 lakhs per QALY at 10 years, we have a willingness to pay, which is just half that. And if you look at the cost of medications per annum, it's only 6,000. Remember, in the whole scheme of things, the annual health spend in India was just 6,600 rupees per annum. That's $80 in 2022. So what does this tell us? MIGS is not cost effective for most low to middle income countries. But what can change that equation? Well, the cost could come down, or complications could come down, or the need for future interventions may decrease. These help the eye curve. But if the medication becomes more expensive or less effective, then the eye curve increases. There's been several advocates for innovation in this particular area. And you've seen the RD, which brings the cost of what essentially is a barbell down by a sixth. And look out for other innovations locally in India as well. Now, of course, we do want MIGS, the low invasive profile, the low risk, the short hospital stays, the minimal post-operative hospital visits. It all sounds very attractive. But in reality, the high device costs really make sure that this is only for a certain population. And this is not giving us equity amongst the access to healthcare. And this is a moral imperative that we need to pursue. There are also lack of insurance coverage and surgeon training gaps that lead to these bigger disparities. We all want our calorie-free dessert, and this is where there's new devices or device-free MIGS may come into its own, which bridge that gap between efficacy and accessibility. Now, when you follow the money, you can see that there's a massive increase in the Medicare Part B expenditure. It rose from 52 to 180 million between the 10 years of 2007 to 2017. And a lot of this was mediated through the eye stent. In actual fact, almost 60%. Now, whilst this was occurring, the total contributed by trabeculectomy and glaucoma drainage devices fell dramatically. So you can see that it's not just about the science. You can see that innovation here has been driven by reimbursement. So the future must be equitable. We've seen local innovation helping with devices like Oralab's RD in India. We've seen task shifting. It's not necessarily useful to train highly specialized people like glaucomatologists like us. It might be useful to train the cataract surgeons to get these out there into the periphery. And Paul Healy will know that some of our colleagues like Ashish Agar has taken these stents out into the outback and has used them on Aboriginal populations that would otherwise not have access to these things. Now, the politicians must get involved as well. There should be some subsidies increasing from the local governments, and even things like tiered pricing. In other words, the more you use, the price comes down. And perhaps this inclusion in universal healthcare coverage, like the Ayushman Bharat model. And here we're only even talking about open angles, not even the visually destructive closed angle glaucomas that we get in Asia and India specifically. So look at this, precision medicine. Precision medicine means what works in one person may not work in somebody else. And this is a wedding that cost $600 million US. The father of the groom, so the mother of the groom, wore a necklace which was $4.5 million. And then less than an hour's drive away is the birthplace of Gandhi. So I'm going to make a prediction here. I'm going to say that GATT is going to be the preferred MIGS of choice for this region. It's coming up in size. Currently you see more of the slicing procedures with the hooks, KDBs and bang techniques. But in terms of your bang for your buck, in terms of how much does it cost to get a millimeter of mercury decrease, GATT comes in very well. Now, and I predict that, yes, they do have some downsides with the side effects with the bleeding. It's almost universal in every single case. You do get a very good IP reduction, and maybe slightly better than you would with the slicing procedures with a hook. So I think this is my prediction for the future, that as we've seen an increase in countries like Eastern Europe, you can see probably increase in this part of the world as well. So just to finish off with a quote from Gandhi himself: recall the face of the poorest and weakest man you have seen and ask yourself if this step you contemplate is going to be of any use to him. I think this is very important for us to look at the accessibility of healthcare and look at the work and innovation that has come onto the scene more recently, and don't let it divide the rich and poor, but use it to integrate and bring them closer together by using the mother of invention to bring back accessibility. Thank you for your attention, and most importantly for your action. Thank you very much.
Thank you, Shamira. Well curated talk about the health economics. Shamira, over here. So in India, the non-device goniotomies are very, very popular now. They're picking up, especially the GAD bank. And now we are going to launch in today's session the dual hook. It is something like the LAN or the Tanito hook. So India is picking up in mix, and as Dr. Mori was talking about mix in angle closure, we are doing a lot of mixed surgeries in angle closure also nowadays. So because of the economical issues, India is targeting for cheaper non-device based mixed procedures. Thank you.
It's great to hear. Yeah, thanks.
Shamira, one question for you. So we totally agree with you. I think GATT is going to be the future for MIGS. But in terms of patients who come with early glaucoma, would you recommend a 360-degree GATT, or should we do a hemi-GATT or target less of the TM instead of 360 TM for early glaucoma?
Right, so the question is GATT titratable? I actually think if you should do just as much as you can. Ultimately, you're not going to get hypotony. So if you can do a full GATT, then you should go for it. Of course, you weigh that up with the downsides of bleeding. And I'm sure we've all seen complications where there have been quite significant hyphema, and you have to even go back into the eye to go and remove this. But of course, thankfully, these things are rare. Maybe with better picking of patients, we can target our responses. I mean, fantastic work by your team on looking at targeted areas of mix to get the best out of it. Yeah, but I think that when you don't even need to go and do that and just do a hemi-GATT or a full GATT, that would be the way forward.
Thank you.
I think the house should not take a wrong message. As Tanush sir, for severe glaucoma, we would advise a 360-degree GAT. But for mild to moderate glaucoma, I think a hemi-GAT or a limited goniotomy would give better result than instead of traumatizing the whole 360-degree trabecular meshwork.
I think it's very interesting because the trabecular meshwork is not a passive barrier, it's not a passive filter. There are active parts to this. So we have to really look into what are we doing when we do these procedures, and when these slicing procedures, are we actually damaging the back wall?
Yeah.
That's important, yeah.
Thank you, Shamir. We have one question for Dr. Paul Healy. So, Paul, this very nice talk on the polygenic risk. So, if a patient has an investigation today and he has investigation after 5 years, so would that risk change? It can become less than baseline or become more than baseline. So, how would this one test really change the management?
Well, the genetics is not going to change over your life. So whenever you do the test, that's all you need. And that's, of course, one of the appealing things. If this is a test you only do once in your life, then it's going to be much more cost effective than, for example, a screening program where you might need to return. So, I think, I guess the important point about genetics is that, in a sense, we don't know what we're doing. So we've identified these polymorphisms that predict disease, but we have no idea what they're, for most part, what they're actually doing, how they interact, whether we should be looking at the exome, we should be looking at the genome, and of course how these genes interact with environment, which I think is the implication of your talk. What are the epigenetic effects? All those remain unknown. I think the best way to think of this is simply as another risk factor. So you take a family history, because you know of the strong association between family history of glaucoma and incident glaucoma in the patient you're looking at. This is just a more sophisticated way of doing a family history with a much stronger predictive result. And I think in terms of health economics, when we were doing the analysis in a developed country like Australia, the big economic benefit of polygenic risk scoring is actually not in detecting the 50% undiagnosed glaucoma. It's in not having to ever screen the ones at low risk. So, if you want, as Shamira said, the future should be equitable. If you want equitable healthcare in India, then it's just as important to know who doesn't need treatment than who does. And if you can identify someone at 10 years old and tell them that all they need to do is when they get to 45, they need to go and see a heart doctor because of the genetic risk, but they don't need to do anything else. That's a huge saving of health resources, which then can be diverted into picking up those more serious diseases. It'll be interesting to do the calculation in India, but in Australia, you save more than twice the amount of money than you spend by doing this test, and that includes the cost of the test as well.
Thank you.
So I have a point, Dr. Nitika, what she said. We are seeing that mix has got a mixed result, that the meta-analysis has shown not to be so effective as compared to cataract surgery. But most of these studies have not been done with a targeted therapy, targeted approach. If we are going to do a targeted approach with or without cataract surgery, in maybe next 6 months or 1 year, we'll know actual efficacy of mix. That is the thing will change the modality of treatment with mix in next 1 year or so. And that's what we are now doing an ongoing. There are 3 RCTs we are doing with the targeted therapy with and without cataract in various types of mix.
Thank you, Dr. Mishra.
One last question for Dr. Ben. Ben, with your talk on AI, I think, with your talk on AI, don't you think so? In the coming years, we'll be overdiagnosing glaucoma because AI is becoming more and more popular among the whole masses. And here we have the scoring system where we says that the early detection will prevent the health economics. So there are two contradicting statements over here. So do we think AI is going to replace and increase the burden of glaucoma?
Yeah, so this goes to the point that whatever AI technology that we adopt has to be adaptable to the capacity or the ability of a healthcare system to actually deliver care. Usually when we develop these AI algorithms, we pick an operating point, which means along the sensitivity specificity curve, we pick an optimal point. But this point can easily be moved so that if there is an over detection of disease, that we shift the operating point to a higher sensitivity, lower specificity point to capture the people at higher risk. And so in Los Angeles County, the public healthcare system is very strained. It can't actually see that many more patients. So we operate under this high specificity, low sensitivity cutoff. But this requires a constant conversation between the healthcare administrators, between the hospital system, and the people developing the models to serve them. So no, I don't think that AI will necessarily lead to an over detection of disease, but we have to constantly keep in mind what the capacity is when we pick our operating points for the models.
Thank you, Ben. So before we conclude this session, Tanush sir will have the launch of the Made in India Mix Hook, the Dev Dual Hook. I request Dr. Devendra to please come on the stage with your play cards and everything.
Precision-engineered, economical MIGS instrument designed and developed in India. It is a dual microhook, a bidirectional, single-handle instrument designed to enable trabeculotomy in both directions without requiring instrument exchange. The key features of the hook are angulated neck for trabecular meshwork access, a fine shaft for precision manipulation capability, 2 opposing cutting tips, an ergonomic ribbed handle for superior grip and control, a fixed angle working tip for accurate positioning and consistent results. Let's look at the surgical steps. After completion of phacoemulsification, the necessary adjustments are made for the MIGS surgery. After docking the gonio lens and ensuring end-face view Dave dual hook is introduced. First, the right-sided goniotomy is done. Without the need to flip the instrument or come out of the anterior chamber, the left side is treated in continuation. Post-procedure, here you can see the open Schlemm's canal. Here is a case of pigmentary glaucoma where DDH trabeculotomy was done. Post-procedure, one can appreciate the collector channel staining with blue dye as well as blanching at the treated area. Postoperative evidence of treatment success can be seen here in AIOC2026, showing a well-defined cleft in the nasal angle. Some of the advantages of the Dave dual hook are: it streamlines the surgical process. It is the most economical MIGS in India. It reduces the need for multiple entries in the anterior chamber. Completes trabeculotomy in one single time. Easy to use for novice surgeons. This glaucoma week, let's pledge to unite to fight the silent thief of vision. Add Dave dual hook to your armamentarium today.